Everybody, it's Kevin and it's Donna, and welcome to another episode of the Med List. Donna, today we've got a really fun one. It kind of reminds me I'm going to give some shout outs to some family. So I've got background wise a lot of folks that are in construction, right? And so you've got general managers on projects and you've got specialists on projects that they're kind of delegating to do different things. And to be successful for a project, they have to have an understanding of how do things go in stages. How do you put things up? Does the drywall go up first? Does the electrical go in? Does the plumbing go in? What holes have to be established? What has to be checked by inspectors? All of those things to be able to coordinate. And so we think of that, I think, when people are building their homes or when they're just working with their families, but we don't always think of that with healthcare. And so I'm really excited with our guest today to talk a little bit about something that we don't talk about, and that's how do we know what in the world each other does, and how we avoid stepping on each other's toes and being able to collaborate successfully. Anything else to kick off our episode, Don?
Kevin, right in my intro of MedStrong, I talk about being the daughter of a carpenter and how I learned about the importance of structure and keeping it strong. But things need to change, right? We also need to paint walls and maybe do a little reconstruction or remodeling. So that's what we have to do when we're in healthcare.
I love it. That sounds perfect. And I'll tell you a story later about how you don't do orange peel. Don't ask Kevin how to do it. All right. Thanks, everybody, for joining us today. Really excited to bring Stephanie on board here and have Donna introduce her to jump into a fun conversation.
Yeah. So, hi, Stephanie. Thank you so much for joining Kevin and I. And I've known Stephanie, number of years at this point. Probably a good, I don't know, 14-ish or something like that I want to throw out there. But Dr. Stephanie Conway-Allen, she is a PharmD, and she's at Mass College of Pharmacy and Health Sciences. She actually does a lot in community pharmacy practice. And she was a part of a residency with Walgreens way back when. I won't give the dates necessarily, Stephanie. And she does so much in teaching not only pharmacists, which she's amazing at, but she also teaches a lot of other healthcare professionals, such as the medical residents, nursing, physician assistants. You've done work with dental too. So many areas that you have shared pharmacy knowledge with. So glad that we get to hear about that education, but also your practice site too, where you are in ambulatory care and working with so many other healthcare providers. So welcome, Stephanie.
Hi, thank you. It's so wonderful to be here. I'm very excited.
No, it's so good to have you.
Absolutely. So if you want to tell us a little bit more about you and some of the other things that you might like to highlight, but and then just if you want to tell us a little bit about all the areas that you teach and practice, just to get the audience all on one page.
Perfect. Yeah, excellent. So hi, everyone. So my name is Stephanie Conway-Allen. I'm an associate professor over at MCP, which is also my alma mater. I'm born and raised in Worcester, Massachusetts. And so I'm right here close to home with my school and my schools. And I currently am very involved in the Worcester community, as well as various different colleges in the area. So over at MCP, I'm involved in different ways in a lot of different multidisciplinary areas, which is one of the things that I really did want to or I'm excited to talk about. I do teach, as Donna mentioned, within the PA program. That's the physician assistant program. I also do a great deal of IPE, or interprofessional education facilitation, and assist in coordination in whatever ways that I can. And those types of IPE activities involve dental hygiene, optometry, acupuncture, nursing, PT, PA, sonography, et cetera. And so really sort of dipping my toe into so many different areas pretty often. But one thing that I do appreciate more than that even is stepping outside of the academic space and realizing how much multidisciplinary and interdisciplinary, care and work that goes on. I currently practice at an outpatient family health center, and every day that my students are on rotation, they're working with with medical students, with physicians, with residents, with PsyD fellows, with postdoc psychology fellows, with PA students, with scribes, with nursing folks. I mean, just a lot of really multidisciplinary and IPE focus across the spectrum. And one thing I think is very important with, sort of thinking back to that carpentry analogy of sort of laying the levels and laying all the different, that foundation. It's not just one nail by itself, right? That nail has to hold on to something. And if it doesn't know exactly how to stick into that wood, because we don't know what type of wood it is, and that's not really going to be helpful. So I like to think about IPE and, that interdisciplinary, multidisciplinary, multimodal sort of approach to healthcare as being sort of similar to that. So again, I told you guys, don't let me go off too much on a tangent. So we can rein me back in and focus with a question. I apologize.
No, you're fantastic. I think the one thing I was doing prior to the show, I was looking at a study, an article that was talking about all the different health professions out there, Stephanie, and it had over 250 professions that were available. This was 2015. So by now, according to all the other escalations, we're probably at 250,000, professions. But all kidding aside, because it's so massive, right? Help for our audience to understand a couple things. When we've got those many people involved, right? Why is that a good thing for patients? And why is it a bad thing for patients? Like, what are the pros and cons of having so many healthcare professionals on your team?
That's wonderful. It's such a great question. So the first, obviously, I'm an optimist, so I'm immediately going to go to the many pros, right? So obviously, we're talking about, we all have a general sense of what the heart is and how the heart works. But guess what? The pharmacist is going to be the one that knows exactly what medication is going to be helpful or not helpful in particular situations, as opposed to the cardiologist that's going to have a little bit of a deeper understanding of the actual, the ventricles and the atrium, right? Like that's a little bit different as opposed to the nephrologist that's also involved. And that individual that's going to be placing lines or checking for, the effectiveness of dialysis or looking at different ultrasound imaging, right? So there's all these different areas that are totally involved in this random disease state that I just created for you all, right? With all these different needs that someone might have. And so, yeah, you've got the expertise, but in addition to the expertise, we all learn more when we're able to work together, which is super important. But I think that one thing that's especially, pertinent in this whole discussion is the importance of the patient. I've personally, when I think about someone taking care of something that they know very, very, very well, and that person being involved on my team, that makes me feel pretty good. So if I'm going to be going to see a cardiologist, that's wonderful. But I know that the actual organ that is the heart is not the only thing that we need to talk about. There's so many different areas. What about my access? What about my insurance? What about social implications? What about monetary implications, pharmacoeconomics? What about side effects that are now, or different cascades that might change my, my future disease states or general well-being. And so, again, there's so many different pieces and areas, and it's only when all pieces and areas sort of come together that really allows for that patient, I think, to feel comfortable and confident knowing I'm not talking to the pharmacist who knows just drugs or just talking to the neurologist who knows seizures. I'm talking to the whole team who all have a good sense about various ways that this disease state might affect me. And therefore, they're all giving their input, working together, collaborating. And it happens more often than it's a good thing, though, but it happens more often than not that I might have a comment and a physician might go, oh, wow, I didn't even think of that. And it might not even be pharmacy related, but it does just give those different perspectives based off of experience, academics, knowledge, specialty, and having all of those pieces for me as a patient or even just as a consumer, I would love to have the best of the best, or at least the knowledge base covering all areas. When you go to take your car to get fixed, you don't want someone that just knows how to change the oil, right? You need to make sure they know all areas. Yeah. I'm really coming up with these analogies off the top of my head, by the way. I'm pretty proud of myself here.
And you're knocking it out of the park. No, with that, I think that's really helpful for us to kind of digest on. Yeah. It is great to have a team. It's great to have a team that has multiple kind of points of entry when it comes to knowledge and perspective. So they have a good idea of what is happening on a very complex, diverse system. So to be able to understand that a little bit deeper, the complexity and diversity isn't just our bodies, right? The healthcare system in itself is extremely complex. So there are allied healthcare professionals that are just as important to be able to tie into things when it comes to executives and billing staff, et cetera, social work, to be able to bring those folks together and tie together resources that are meaningful. Where have you, Stephanie, and Don, I'll pass it to you after this one, but where have you, Stephanie, found like some of the biggest highlights in your career of doing some of this interprofessional work on tying these individuals together with the rest of the team makes a huge difference?
Yeah, I mean, I feel pretty fortunate to have almost pretty regular examples in that I work with an institution that focuses on comprehensive care and comprehensive care teams. And what this essentially means is that, you know, we have the pharmacy team there with the medical team there with the clinical social work there. And that's an automatic, and that's with every one of these visits. And these are higher risk patients. These are patients that, you know, perhaps might overutilize services, not because they want to, but because they're not being managed appropriately. And so we have, you know, these comprehensive care team visits. And the first person that is going to ask the questions is always going to be that clinical social worker. What are your issues? Why do you think that you're here? What is of the problems that you have? What is your number one issue? And somehow we end up sort of pulling it all together through the medical team that's there, the nursing team that's there, whatever social workers are there, as well as me and my pharmacy team. But that is something that, again, it's not a one particular situation, but I do get to see it happen relatively frequently because of the work that my particular health center has, you know, actively, you know, pursued in regards to trying to get patients, you know, better cared for, the ones that require more help, more assistance, more discussion, more caretakers being involved. And so, yeah, this is not something that unfortunately is easy for all patients to have access to. But for those that do, I absolutely feel that it makes a big difference. And the follow-up is always such a positive thing. And if it's not, it still feels like it's headed in the right direction, because it's just showing that if we needed that much time to make these steps and we're still not where we want to be, that's okay, because now we still have more steps. But thank goodness we had that interdisciplinary team to identify all of those different areas, and then we can continue to improve.
Awesome.
That's great. Stephanie, I know that we're both involved in various interprofessional education at the school and also with other schools. And as we spoke, you work with the medical residents and nursing, and I've also done some of those programs as well. Let's talk a little bit about that education piece. And just so that everyone understands what interprofessional education is, it's when two different healthcare disciplines come together and they learn together.
Mhm.
So, and it has to be at least two. So often we have more than that. So, which is wonderful. And I always love the aha that comes when we have these programs together, and the learning about, oh, I didn't know you went to school for that long, or oh, I didn't know that that was your degree, or you know, those simple things too.
Mhm.
Wow, we really figured things out, and I didn't understand that this discipline worked in this element for the patient's needs.
Totally.
So I would love to hear from you as to what, you know, when you're teaching these students and even collaboratively teaching the students, what are some of the things that you're teaching them as a pharmacist versus, you know, that is, and they're not going to school for pharmacy. So I'd just love to get that perspective and any ahas or any wows that you've received from the students that you've teach.
Yeah, absolutely. So this immediately, as you were talking, I had a few different kind of things pop up for examples. But one in particular, I teach within the pharmacology program at an advanced graduate through a nursing program. So these are NPs that are going to their doctorate NP. They're currently just going through nursing school and have gone from start to finish sort of through their nursing program, or they've worked for many years as a nurse and now are going back to receive their advanced degrees. And so essentially these are students and they have cases and they work through everything. And I go to serve essentially as a pharmacist pharmacy consultant. So it's somewhat mimicking real life in that, imagine you're in the pharmacy or you're in the hospital setting and you've got this question, pick up the phone and call the pharmacist, or go, walk down the road, walk down the way and ask a pharmacist. But I think that I have often little aha moments during these sessions, because as you're walking around, some of the questions that the pharmacy folks think of, because again, our brains work differently than a physician's brain works differently than a nurse's brain works differently than, a dentist, right? I mean, all of our brains work a little bit differently, and that's why we're in our different discipline. And so when you're trained to be a pharmacist, we have certain questions that we think of. And one thing, and this isn't going to be as poignant as you might, and I'm leading up to, but I remember when I asked a question, or I made a comment about adherence and cost to the nursing students. They had thrown something, it might have been antiviral, and then they threw a cyclovir 5 times a day, or I don't know, whatever it was. And it was through sort of a discussion of, have you ever thought about adherence being a concern? Well, what do you mean? Well, what do you mean? I mean, you're going to send this person home and ask them to take something 5 times a day, and also, did you consider the cost? Is this available generically? And I kind of just posed a couple of those questions. And then all of a sudden, they weren't thinking like a nursing student. They weren't thinking like a pharmacist necessarily, but they were all of a sudden thinking just as a healthcare professional who needs to make sure that their patient is cared for. And so all of a sudden they were looking up formularies or looking up to see if generics were available. And it was something that was maybe more aha for them, but I definitely found it to be really nice, because again, as a pharmacist, my brain immediately goes to insurance coverage, cost, accessibility. Wait a minute, that's a drug shortage. No, that's not the way we want to go. That's how my brain works. And these individuals just went for what was first, what was listed, and there was a brand name product at the time, or 5 times a day. It didn't really make a whole lot of sense, but that's just what they thought of. So if they had a list of 5 drugs, they just picked one, as opposed to the pharmacy side of things. And I think that the groups that I talked through that piece with, I definitely feel had a little bit of aha, realizing that it is not just what the guidelines say is okay. It really should be more of a patient-specific, thoughtful conversation.
Wow. Yeah, I think that's one interesting thing there is the patient advocacy mindset shift, right? That you actually put yourself in the shoes of a patient to think about that is a really interesting aha that I feel like happens more often when we collect a group of professionals together, right? Then we start to take a like-minded thought process, which comes directly from the patient looking at the system rather than vice versa. The one thing I was going to ask you, Stephanie, related to that is when I've trained students, or when we've walked and we've talked and worked with patients in general, especially interprofessional student groups, the one thing that I think is so fascinating here is that we don't often get enough exposure of us working in the exact same setting together, literally in the same room, sitting down, working with the exact same patient. And so a lot of the questions are very exploratory, right? Let's just like, what do you think? What do you do? Where does it come from?
Yes.
How has that changed over the years, Stephanie? Because me seeing students and working with them is about 5 years removed right now. And so how is that changing? And what are the kind of new and exciting things in the future to make sure that we're really step for step on an interprofessional basis?
Yeah, that's a really good point, because then we throw in COVID in the mix, and that really kind of tossed everything up, right?
Yeah.
I mean, there was a time when, at the health center, our students weren't necessarily there, but we were available remotely. And so, now you're talking about questions not only not being in person, but now not even being remotely on the same site. And now I might be on Zoom, but I'm not available and they're calling. And so it definitely got a little bit tricky. So I actually think that incredibly difficult time has now sort of set us up to improve. I definitely think the use of technology and the comfortability that we've all had to adopt with technology has certainly helped. I will 100% sort of, I've seen, rounds that are live/remote rounds taking place because you want those team members to be involved, but if they're not able to physically make it. So now we're actually able to adopt and use these technologies that we didn't. I'm telling you right now, 5 years ago, I did not realize I would be as efficient as I've had to become using these different things. And so that's one thing I think is that's definitely been helpful. The other thing, I think it's also, to be honest, all of the providers now are coming through always working with other disciplines. And so it's ingrained into their academics, their idea and their vision of what healthcare looks like. So especially here in Massachusetts, right? And, and I know our school, we're up in New Hampshire as well. Like I know that, these folks that have questions, that are the physicians, their attendings now, they went through their entire academics with interprofessional collaboration. And so all they want to do is ask the pharmacist. They don't even want to, no, I'm not answering. No, we need to talk to the pharmacist, or we need to double check with PT. And I have a great person in acupuncture that we should talk, that we should refer them to. And so I think that the general mindset, honestly, across the board is transitioning to multidisciplinary, really respecting and appreciating roles and responsibilities of others, and using one another in a good way, right? Like we should be relying on one another. So it's not just that 1 + 1 is 2, right? Let's use that synergy, and you've got an idea and I've got an idea, and we both have the actual academics and knowledge base and specialty to support it. And there's not this idea of like, but we're so separate. So I feel like just the general culture is one that's kind of pulled things together, and that on top of technology and the students and the healthcare professionals coming through school now. I mean, they are far more technologically savvy than I could have even thought I would have been going through school. And so those types of characteristics and abilities and that sort of funneling through and advancing through our academics, if that makes sense, and through our health centers. And I think that that's a really great way to continue to sort of have that point of care, consultation.
For sure. No, I love that cultural shift.
Stephanie, are there any particular tools that you either teach or use in your settings to help with the communication between the various disciplines? So for example, I love the SBAR approach, and I know that in some of the programs I've done, we've actually practiced that, where it's the situation, background, assessment, and recommendation. So I really like it because I love the way that it's taught, where you actually say the actual words as you're going through. Here's the situation and the background is, and here's my assessment and my recommendation, kind of thing. I just love that. So, so I think that works really well. But I'm just curious, is that a tool that you would typically use? Is there something else that you use? And do you find that it is effective in actual practice too, where, maybe you're seeing both sides?
Yeah, absolutely. It's great that you mentioned that too, Donna, because the SBAR, I teach it in a couple of different places in our Intro to Patient Care course. So I teach it when we're talking about patient-centered communication and communicating with healthcare professionals. So we talk about what the SBAR form is, and again, usually at a very, very elementary level at that point, because it's introductory. Now, as our students continue to progress, once they come into a lab that I facilitate and coordinate in the summer, they will actually use that SBAR form every time that they communicate with the provider. The way we have them communicate with the provider is, I suppose, slightly archaic. They pick up a phone and they have to call, but that's just the way we have to do it, just to get those communication skills down and actually reading through the SBAR, and they use those SBAR forms. So within the pharmacy curriculum, 100%, the SBAR is the quintessential, this is the way you should communicate, because it helps you organize it, but it's not too specific, right? Like it's just enough to help you organize your thoughts and communicate with your healthcare professionals. When it comes to being in the clinical setting, we kind of at that point are always doing SBAR. We just don't always refer to it as SBAR as much, so I guess I don't say, hey, what's the situation? What's your background? But, through our conversation at that point, having used the SBAR, at least academically speaking, for the past 2 didactic years, the hope is that it comes somewhat naturally. That's a hope. But yes, so the SBAR form 100% is a great tool. Outside of that, I don't use anything in particular. I step outside of the the SOAP note format. I have the students do notes a little bit differently, but that doesn't quite have to do with the interdisciplinary side of things or communication side of things. That's just me on a personal preference of the length of the document that I want to read from an academic side of things.
That's super. So from an SBAR standpoint then, so our situation is that we have a shortage of healthcare providers, and the background is typically a siloed primary care model. Give me the assessment and your recommendation on that, Stephanie.
Oh man, get more practitioners involved, I guess, right? Get more practitioners involved, get more patients involved in their actual care. I'm always so taken aback by how many patients are not familiar with the fact that they can use their MyChart or access their own medical record from home, or to ask that their provider do that and give them access. This idea of I'll let you know if something's abnormal, and then not talking to your patient. Those types of things. I definitely think that there are small sort of little silos, and people want to stay within what they know, and branching out too much can be tough. But I just would encourage institutions as a whole just to adopt a multidisciplinary model across the board, and let more let more folks be involved. Again, where I'm from here in Massachusetts, we're involved. We're very involved, but I know that's not always the case in other places. There's no reason why your pharmacist can't do medication therapy management and actually check up on your patient to see how are you doing with your medication. I have a good rapport with you. Why don't we have a conversation? And so I definitely think of a primary care, super important, having that place, that touch point always. But I just think getting more people involved and having patients not feel as nervous to talk or ask about their health care, even if they're perfectly healthy. It's always this sort of taboo thing. Well, no, you don't need your chart, or well, no, we'll let you know if something's abnormal. And so I would just encourage more. I'm really on that patient advocacy side of things here. I guess to get out of that sort of silo of just being stuck within your patient care little world, I would say to start opening it up to other professionals and let your patients be a little bit more involved in their care.
Yeah. I think it's true that we need to stretch and be a little bit uncomfortable, maybe reaching over to another professional and just saying, hey, I saw this, this patient, and think it might be a good idea to do this kind of thing, or just have you, I've been thinking about this. What about this for this patient? And I think it's uncomfortable for people to do that because of the silos that have existed for so many years. So kind of stretching and reaching. And I always love the comment, you gotta stretch and be uncomfortable in order to get comfortable again. So I always love that, some of the things I do when I'm talking, when I talk with patients and they're saying, I can't talk to my doctor and ask that question, or I can't talk to this specialist and ask that question. And when I heard that so many times, I decided, and again, I'm going to just bring up my book, where the communication with different folks is in there. Like, what if I go see my specialist? What if I go to the pharmacy? What if I'm in the hospital? What are some of the questions I can ask? So having that guide and getting patients a little bit more comfortable. I'm just going to digress for just a minute here. We had a great debate today in one of the electives that I have, and we're talking about auto refills. And there was one debate saying, is auto refills an issue for deprescribing? Does it get in the way of deprescribing? Do medications continue to show up that are supposed to be discontinued? And so this was the debate. And one group was saying, it's up to the patient, it's up to the doctor, it's up to the pharmacist to all communicate and be on board and know exactly what's going on. And then the other group is going, oh no, there's too many, holes in that Swiss cheese that can get these meds to go through. So we really need to be not assuming and thinking about how we can better communicate with patients and how and get patients comfortable to
Mhm.
communicate too. So, any suggestions on that? Do you, especially in your clinic for ambulatory care, trying to get patients to get comfortable having these conversations and asking questions and feeling empowered to follow up themselves with the next person they're going to see?
I know it's so everything you just described on is exactly what you want, right? Like you want your patient to have all of that. I honestly, I really just think it's building whatever rapport that you can. And I implore all of the, especially community pharmacists that are having the FaceTime with their patients to really just use that and realize that they are your patients and that maybe you might be that safe space in their healthcare system. And maybe you're that person that can explain to them why it's okay for them to take the benazepril and why they needed to be concerned about potassium or whatever it is, because really it can be so overwhelming, just navigating anything, whether it's a disease state or just an urgent care visit. And so I completely understand it's scary. It's there's so many unknowns. And so I would just ask for, I would, again, all pharmacists, guys, like, come on, really make sure you're building that, rapport with your patient and asking them to ask you questions because they might not get the answers that they're looking for on, otherwise, and be that soundboard for them or be that person to really sort of answer their questions, their concerns, and talk to them. And that might be the difference. And so I don't really know how to step too far out, but I guess this is just my little soapbox of just if the more that the pharmacists do, engage and take advantage of in a good way those positive relationships with your patients, I do think that the more positive outcomes will result. And so, like you mentioned, the S and the B, right? The situation way back is that there's a shortage of pharmacists, right? So that's a larger issue that they need to sort of address because they need to improve the pharmacists' quality of life a little bit, get us happy again, get us back in there, get us smiling, get us doing and being the number one most trusted healthcare professional, which is what we want to be. But we can't do that as much and build that rapport when things are so hectic and in that retail mindset of, we're not selling scarves here. We're talking about medication, but we still have that retail as opposed to community pharmacy mentality. So I think that once we sort of step back from that a little bit and encourage our pharmacists to really be that patient advocate, I think that's one way that we can encourage those patients to actually talk to those specialists and ask questions and empower themselves a little bit over their health.
Do you feel, Stephanie, like there are those natural referral pathways? They're already in existence. So, for example, if we worked with the VNA, the Visiting Nurses Association, had some incredible colleagues that were expert nurses in infusion, had some fantastic PT and cardiac rehab individuals that were great to be able to bounce things off of. And it was so simple because literally they were sitting in the desk right down for me. And I would go say, hey, can you help me with this? I have no idea how to address this wound. It's not healing the way I thought it would. What should we try next? And those are great interprofessional conversations, but they happen because proximity, like I was literally right next to them. Right. And that's what happens in a lot of these collaborative care settings. When we're outside of that, you just mentioned, community pharmacy and pharmacists as a whole, like if the folks watching don't know, really struggling with just filling seats at academic institutions. And that is not any different from what we're seeing with our providers. Like we're seeing MDs, DOs, PharmDs just aren't going into the profession like they were at the same rate. And we have seen for years our nursing colleagues go through strike after strike because of what's been pushed on them, and it's getting worse on that stance. So when I ask that question for referral, I mean, I do it with a slight caveat, like we have only a limited bandwidth, right? But at the same time, have you seen with your work in interprofessional education, some of these referral pathways in the community be created?
I'm going to be honest and say not really. I don't know. I don't know how these pathways, if you're talking about just from a community pharmacy standpoint, that's really sort of hard. For me, being in an actual, outpatient family health center, I'm in a little, I'm sort of right in the middle, right? So I'm not an inpatient, I'm not in the community, but I'm right there, chronic disease management, hopefully preventing patients from needing to go to the hospital, and
Right.
then getting them situated so hopefully they have the best and most productive experience at their community pharmacy. But in regards to referral, it is sort of tough. So, the education is there regarding when do you need to go and see a provider, right? When do you need to go and talk to someone because this is not something you can treat on your own, or because I would be alarmed. But aside from telling your patient you need to go to your provider,
Mhm.
that is as far as, and maybe I'm a bad practitioner because I don't have any more a better response to that, but I feel like that kind of is where we are a little bit stuck. So an area which would be tremendous, right, would be, are there, direct collaborative opportunities, or, could there be, here we've got a speed dial, could there be, if you've got a patient that's coming in, just sort of like a minute clinic, is there a telehealth opportunity for someone? I don't know. And so I think that the opportunity there is tremendous, but in regards to the referral process,
Yeah.
in the community, I feel like it typically might be a phone call to their provider if you're able to, and you have a really good rapport with them, and you've got the time and resources, of course. But outside of that, I do feel like a lot of it is just in saying to the patient that
Yeah.
you need to talk to your provider, or take care of whatever the issue is, and that's unfortunate. But I think that that's unfortunately where we are.
That's super helpful. The only follow-up I have on that one is this. We talked a lot about students and early education components of IPE, but the one thing I wanted to make sure we got into a little bit before we run out of time is what happens to an old guy like me when I want to stay up to date on what is interprofessional education, right? After you've been out of the educational process, the structured didactic educational process, and now you're just doing your annual CE, et cetera. How do you still stay in that space and understand and grow in an interprofessional way?
Huh. That's a good question. I might ask Donna to provide me with any insights into that as well. I mean, aside from, it is certainly just with CE, interdisciplinary opportunities are absolutely there in regards to, CE. Um, uh, unless you're affiliated with an academic institution, I'm not entirely sure about what that truly looks like. And I apologize that I don't know. And that's another thing, right? Like, where this is a great conversation because we're identifying where there are some gaps. Because if, outside of being in academia or working in an actual institution, a health system that has interprofessional education, then how would someone start to work with PT or PA or physicians or whomever? And so, yeah, that's definitely a need. I think that exists, not just with having CE or different opportunities available, but just with nomenclature or understanding what exactly IPE is, and what the impact is, or even looking at current pharmacists, right? Like, if they've got students coming through and the students are very well versed in IPE, but the pharmacists are not because they didn't do any IPE, it
Yeah.
might seem a little foreign to them even as well. So that's definitely a need, I say. And I don't know if there's anything else that you guys are aware of in regards to that, but that's a need. That's a need, Kevin.
Yeah, I think one area is IPEC, which is the Interprofessional Education
Hmm.
Collaborative, and I think that is a great spot to start and to get involved in. So that would be probably an area where you could learn more about interprofessional education and engage as a professional, as a healthcare professional. So I think that that would
Hmm.
be a great thing. Even just looking, you could look at the World Health Organization and look at interprofessional education or any type of professional resources that we have. The other thing is, I know in the different organizations, national organizations for
Hmm.
um, whether it be pharmacy or other organizations, the American Geriatrics Association, for example, Society, excuse me, AGS, that would be more collaborative to of various um,
Hmm.
of various healthcare providers. So I think depending upon what your specialty might be, you might be able to find some organizations that are collaborative in that
Mhm.
regard. So those are some neat things. The other thing, Kevin, that has been really wonderful for me, and I've been doing this for years, is I've been part of a falls prevention coalition for
Mm.
the state of Massachusetts. And talk about a collaborative group of people from not only like nursing and PT and OT, but people who work with the blind and people who are working on construction in the community infrastructure, the public health officials that we have, senators and Congress folk. There's just so many different people, exercise physiologists and fitness trainers. So it's that Tai Chi
Mhm.
professionals. Just it's just such a great group of people, and we learn so much from each other. And they always love like, so what about the pharmacist, and even learning from me too in regards to what we should do about falls prevention, how it all matters, just like we start off right with this whole structure and carpentry and how we're building in the foundation. It really is multifactorial when we are looking at this whole interprofessional education. So whatever your specialty is, there's probably some interprofessional education group of
Mhm.
some sort, collaborative, that is probably out there. You'd have to just do a little research.
I love that. Yeah, I think that from a non-participatory standpoint, if you're just trying to be a consumer, there's some fantastic journals that are out there that you can subscribe to, right? In
Mhm.
occupational therapy, in nursing, in individual specialties that you can stay abreast of what are these professions thinking about these given disease states, right? Or how are they treating their patients or what's evolving in those spaces? I think that there's obviously another one which we're live to right now and LinkedIn that you can start connecting with folks that don't have a PharmD at the end of their name and then get some perspectives and ideas on what are they thinking about when it comes to the development of technology inside of healthcare, or what are they thinking about when they're looking at
Mhm.
herbalism or cultural medicine kind of components. The one plug, I guess, from a more involved standpoint that I think is great, that I feel like more universities need to grab a hold of, is Washington State University, for example, has the Indigenous Healers cohort, which I'm part of, which is a huge blessing to be able to work with a group of interprofessionals on, some very specific population health related components. And it's so nice to be able to go back to an alma mater and connect on some of those pieces. And I hope that we see more universities start to look at that as being a true opportunity for growth within their individual communities. I do think that what Stephanie was saying, though, when it comes to a lack of referral resources internally, like within communities, and potentially a lack of those that have graduated, an interesting opportunity for us to be able to leverage, a lot of societies that you can go and talk to, Donna, when it comes to
Mhm.
what is your community currently doing to develop their own community? So city planning,
Mhm.
and when it comes to
Yes.
Lions clubs and other groups that are
Yeah.
talking about what's
Yeah.
going on in our community and bringing those professionals together, I think could be a really interesting advantage if we could have that happen
Mhm.
more.
Yeah. Great stuff for sure.
I love it. I think that's really helpful. But Stephanie, my last question for you was this one. With your job right now and the number of things that you have to touch base on, like you have to be the specialist amongst specialists, right? You have to be the pharmacist to give perspective to all these different professions and get their insights and their thoughts and the way they think about things to shift just slightly so that they understand a little bit more from what we're doing. What do you think in the next 5 years or so? What are you the most excited that you're going to try to do inside of your current role to change IPE?
Mhm.
Hmm. Well, I think it's an automatic that the implication of AI is going to be pretty tremendous, and so I definitely think just uh, figuring out all the different ways that people can collaborate either within AI or even just utilizing. I'm excited to just see some of the different ways that we can come up with activities or roles and responsibility activities or book clubs or whatever different IPE focused academic opportunities. I think that there's going to be a lot with AI that we could of course incorporate. What do I plan to do more specifically? I don't know if I have anything in particular, I'm very much on the AI train right now. And so I definitely feel we're going to start seeing quite a bit of just different things and really innovative things and really great ideas within academic institutions for IPE, as well as just within healthcare institutions with IPE. I could think that the technology is going to continue, not AI specifically, just in general, like our ability to utilize technology is going to continue to improve. Telehealth will continue to improve, and that in itself will continue to enhance IPE as well. And so I think that IPE is so much bigger now than it was 1 year ago, than it was 5 years ago, than it was 10 years ago. And it really is so exponential that it's second nature almost to us here. As soon as a question comes up, give me some IPE activities, I can start throwing them out, different schools, different institutions, different health centers through our program, because it's so just mainstay in a good way. And I definitely feel like the relationship building is tremendous just across the board at my health center, at the university, and within the other institutions that I teach at. So technology is going to be my kind of takeaway here.
Donna knows how much I love this space in general, but when it comes to technology, the one thing I'm curious on for both of you actually is this one. Then that wasn't my last question. I lied, Donna. So this one. You mentioned technology, but the one thing that we didn't talk about specifically that I think is really interesting for both patients and clinicians to hear about a little bit is the role of simulation. When it comes to utilizing augmented or artificial like intelligence, I think is exciting. But when it comes to augmented reality or virtual reality experiences for our clinicians to be able to participate amongst each other, anything that you've been working on, Stephanie, over these last few years, I feel like every institution I'm seeing it go from, we used to have like an Annie dummy, everybody that, you go and you'd push on, it did nothing at all. Stephanie and I are both Office fans. And so there's a lot of funny things we can talk about with that. But then you moved on to the Sim Man, right? And so with that, it had maybe some vocal components that came out. You could bring an interdisciplinary team in to play their roles in a code or other medical related event. And now it's gone even further that you're able to actually put yourself into a triage scene and walk through each individual step. But Stephanie, I'm not the expert here. What are your thoughts on that space?
So in that space, everything you just described is excellent. I think that it's so innovative, and again, thank you, COVID, to some extent, because it sort of really forced some of those those advances to take place. A lot of the different technologies that I've used that were simulation based were a little bit more pharmacy specific. And so, we used EHR Go, we used something was called My Dispense, which was out of Australia, an Australian university. We use those to simulate patient counseling and patient charts and, dispensing medications, doing MTM sessions, preparing IVs, whatever it might be. It's really, really innovative, but it still is simulation and still very computer heavy. When you're talking about there in regards to like dummies or dolls or looking at actual like physical assessment and things like that, I don't have any experience there aside from more the software that I've just sort of mentioned. But I think that it will continue to expand. My experiences again are just primarily with the actual databases that are more dispensing or operations focused.
So I just think it's really important, because we are the Med List, that we talk about the whole interprofessional education and collaboration and really improve patients' med lists, because we're really doing this to improve the health and outcomes of our patients. It really is patient-centered care. And I was looking at some of the models in graphics for interprofessional education, and there were some that had like interprofessional education in the middle, but I really think that the patient is in the middle of all of these folks around. And so I really like to be thinking of that whole patient-centered care and the interprofessional group all around that person, just helping and lifting them up. So that's my take on the whole IPE. So thank you so much. And a little IPE sideway is that, again, MedStrong, the workbook is now out. First person who actually bought the MedStrong workbook was a physician. Thank you very much. And so there we go. Like, talk about communicating, right? But really, patients and caregivers and providers, anyone IPE, you might benefit from this book, MedStrong workbook, and get your copy. It's filled with all sorts of great charts and information, things for patients to fill out, great communication tool, and maybe you'll be thinking of things a little differently.
I love it. I love it. Thank you, Stephanie, so much for joining us today and for all of your insights. It's so helpful. The only closing remarks I think I have for this is just from the patient perspective. Make sure you know your whole team. Get a good idea of that entire team, see the ways that they can potentially collaborate. From the MedList as a podcast perspective, I think there's no better way for the patient to be able to get a personalized experience in medicine other than doing that, right? If you want your MedList to fit you and your goals for your health, then knowing that team and getting a good understanding of how they work together is pretty essential. So with that, thank you once again, and we will see everybody next time for another episode of the MedList.
Bye, everyone.